surgeons like to do surgery? Who wants to go to another meeting? One of the things I've learned is I have key leaders in the corporation, and we sit down and troubleshoot the problems that are happening. So this is the Revolution device that we were just discussing. No capital equipment, simple device, bidirectional cutting. It also has the ability to aspirate.
I snuck it in with a...
And you're getting fired Monday.
And I'm getting fired Monday.
I quit my job, told my wife, I said, listen, I need to sell your house. She said, go for it.
Every single case of a good anterior or posterior perforator vessel that feeds the plantar loop is as good as trying to get a 30 centimeter CTO done.
We guarantee 3 days before you're offered an appointment. We really try to change how we deliver vascular care for the area. That's my greatest challenge.
I never thought in my mind that I would be a training facility, and there you go. So I'm back in academia.
They pulled me back in.
You can never leave.
Two vascular surgeons walk into a bar and come out with a podcast. We are talking everything vascular and not. Welcome to the Life of Flow podcast.
The following podcast is not relating to my teachings and work at Del Cedar Medical Center and is for entertainment purposes only. Hello, everyone. Welcome to the Life of Flow podcast. And today we have Dr. Chris LeSar. Chris is a kindred spirit. He's passionate about limb salvage, passionate about outpatient-based care. And today we talk everything and anything regarding atherectomy and stenting. So I hope you guys enjoy this one. Vamos. Chris, welcome to the Life of Flow podcast. Thanks for being here.
Thank you for having me on.
I always want to express like really profound gratitude on the front end. When people carve time out of their weekend, I, for one, hate when anybody says, can you do this for me on a Saturday? Because that's just like the day that I have 1 or 2 days to myself. So, man, doing this on a weekend, we truly appreciate you, Chris. And I know you're super, super busy. So thank you very much for being here.
For two great human beings, I'm happy to do this.
So other than me, who are you talking about? Because I don't necessarily...
I don't know.
You're talking about yourself and me. Got it. Okay.
Oh, my gosh.
Chris, listen, I love setting up things always. You know, this is your first and hopefully not the last of many conversations you'll have on this show. From clinical to esoterical, from sane to insane. But always on the first show, we love to get background. You know, where did you start your path? You know, what was your family upbringing like? How'd you decide to go into medicine? And how'd you decide to go into surgery? And even more so, how to ultimately say, you know, I'm breaking from the hospital corporate structure. I don't want a W-2, and I want to build my own outpatient empire in a way. And I think that you've done, you know, you've laid blueprints for so many of us. I've reached out to you multiple times. You've been gracious enough to always say, here's what I did. Here's what I didn't do. This is what worked. This is what didn't work for me. And for that, I always find, you know, I always commend people that are willing to sit down and share truthful knowledge that comes outside of books. So I appreciate you for that. But I'd love to hear a little bit of that journey, you know, obviously in a summarized way, because we only have 1 hour to enjoy you today.
It is Saturday. So I guess my story, I'm fairly non-traditional when it comes to the medical side of things. My families are all medical, and on both sides, I'm the third generation physician, and I was the firstborn in that generation. And so everybody assumed I was going to be the doctor. And I ran very hard the other way. Science was my thing, laser optics, and did my master or my undergrad in physics, and then decided that you know, living in a dark room for the rest of my life was not what I wanted to do. I said, I'm a people person. I really like people. I'm going to try this medical school thing. And I kind of promised myself if it wasn't good after the first year, I'd give 1 year. If it wasn't good after the first year, I would go find something else to do. And did anatomy class. And once I did anatomy, that was it. I think 4 out of 4 people around that table became surgeons in that group. But learned vascular and loved it early. I think by the time I was a second year surgical resident, I had 30 carotids and 10 aortas. I was trying to do. We were in a really busy community practice, and so it was eye opening for me. And then, but I was very early in the launch of endovascular. 2001 was when I started my fellowship in Norfolk, and um, a super busy place, excellent training, and I got to start my endovascular, understandings of things. And then I decided to get my first job in the University of Tennessee, working there for 12 years. Love the job, love the work. The there was many things about medicine that's broken, and especially for patients getting people into the door properly. And so I was very motivated to change how the patient experience was, how my experience was in surgery. I wanted to be busy. The hospitals would, you know, block that process. And so I opened up my own thing 10 years ago. And so it's going to be 10 years ago this month, actually.
Wow.
Quit my job, told my wife, I said, "Listen, I want to build a practice." I said, "I want to do it completely different. I need to sell your house, and I can't pay you for the next 7 months." To her testament, she said, "Go for it."
Let's
She
do it.
said, "We don't need a lot. We'll be fine." And here we are. Currently, I've got 3 partners. We have 14 nurse practitioners, 140 employees.
Oh
We
my
have
God.
6 sites around the region that are access points for care, and we allow people to self refer into our practice, and we guarantee 3 days before you're offered an appointment. So we really try to change how we deliver vascular care for the area, and that's been my greatest challenge, and probably the the highlight of my career. I think is building VIC Vascular Institute of Chattanooga.
When you scale, it's one of the things that I'm personally having a hard time with is that as you scale and the volume goes up and the referral volume goes up, that if you don't have the right people managing that front desk, and I have not been audacious enough to say that we could get people within 72 hours through the door, which I believe honestly should be a goal, a performance goal for us. But where I feel my biggest growing pains, it's not on the clinical side and the delivery of care when they come through the door and the ultrasounds are done and the cases are done. That all seems pretty well oiled. But the biggest thorn is how do you manage the moment that you start getting the notoriety, the moment that you start getting the volume, the people that take that volume in for you are just are the key, right? It's the front face of the entire thing. Your referral management coordinators, the people that are like getting the insurance information, the PCPs referrals, like all these other things that need to happen for RCM to appropriately move through is what for me has been the biggest challenge.
You Miguel, one of the questions I would ask is, do you actually spend time on the business aspect of what you do on a weekly basis? You sit down with your key leaders and actually plan what the next week should look like, what the next month should look like.
Yeah, we try our best, but I think that we need to do more.
Surgeons like to do surgery. I mean, that's really what we like to do. And who wants to go to another meeting? One of the things I've learned is I have key leaders in the corporation, and we sit down and troubleshoot the problems that are happening. So it might be front desk is your ceiling that you're hitting right now. How do you then build out the the answer to that, and who's going to be responsible for that? And so we really look at it from a business perspective that way, to say, okay, we need to add 3 more people to front desk and 1 more person to intake. And, that will continue to solve our goal of 3 days or 1 week, whatever your metric you decide is that drives the decision making. So that's kind of how I think about it and how we've approached it.
Yeah, one thing that I loved, I was listening to a podcast the other day, and for some reason, podcasting has become now my go-to source, which I don't know that it's right or wrong. There's a sea of information of people sharing on entrepreneurship and development and business and marketing and all these things. And so I went from a big part of my career just eating PubMed journals to now eating podcasts about business development and finances and how to, become efficient in all these things. And one of the things that I love, because I was getting overly frustrated with, I'll put it this way. Yesterday, I got a call from one of my main top referral guys, and he said, "Listen, I hate to make this call, but my office says that I need to give him another surgeon." And I said, What's happening?" He's like, "The last 2 months, like, I don't know. Are you just too busy? Are you not caring for the new?" And like, it was just like, man, he just stuck it straight through my heart. But what was interesting, he's like, "I hate to call you." I was like, "No, you need to tell me because otherwise I wouldn't know that there's an issue."
Right. And so the volume falls off, or don't get the referrals. Um, again, it's a relationship management, and so um, didn't do this at first. I kind of hired a temporary person to kind of run around and touch base with the primary care that refers, or the podiatry that refers, since we do a lot of footwork. Um, and but currently, I actually have 3 reps. I mean, they're like your the reps that you see and deal with every day. Their job is to connect my practice to the other practices, and to make sure there are no problems. Make sure the phone number and the fax machine number is the right one. Is that the problem? Is here's a hotline to call if there's a problem with getting somebody in. So, actively working that relationship is, I think, critical to success.
Yeah, we call them liaisons, and but ultimately, what I tell them is like, okay, yeah, there's a part of what you do is to get new business. But probably the more important part of what you do is to keep the business that we have. And so you are my customer care line, like you're my concierge to these people. And what happened is that we lost a really strong person in that position because now everything's private equity. So your employees are up for grabs and you can't block them. And there's just ludicrous amount of money on the streets, at least in the Houston area. And so, you get a good person immediately gets into the radar of other companies and they're like offering, 40 and 50% more salaries, spaces that I can't assume, right? And that's my problem, but we have to like zone into that a little bit more. Um, hell, Chris, we can talk about this for hours, and I don't want to derail us because we invited you here today to talk about some really cool technical stuff that both you and I think, share intimately. As you become the procurer of care and the procurer of the devices, and you're not, because in many ways when you're in the hospital, you tell me no, but
Yeah, it's a pain
you're
in the
you're
ass.
stuck to
Yeah,
whatever the contract that they have that month, right?
yeah,
Or you can't really use the devices sometimes that you want.
yeah. You can try new things just to see if, like, hey, do I like this or
You
do I don't?
can't.
Yeah, you
No, you
can't.
got to go
Yeah,
through a VAT committee, and
yeah.
there's red
And they
tape, and it
don't
takes
understand
months.
absolutely
Yeah,
anything. Yeah,
and it's back to the
The advantage of owning your own business and running your business, you get to choose what you think works, what's effective, and also what's cost effective.
absolutely, absolutely.
I know the device we'll be talking about, the Revolution, is a very cost effective device. Has a broad range um, of applications, and I love using it. So I think, Miguel, I think you've had a lot of experience. Lucas, have you had the experience on Revolution as well?
I have on the SFA on the bigger one, which I love, but it was just like one of those things where I snuck it in with a like
And you're
I
getting
say,
fired
and
Monday.
I'm getting fired Monday when this comes out. But yeah, I loved it, and I loved also the lack of capital equipment because we've like turnover is such a big thing where like to it's the one of the most frustrating things ever is just having a device that you've used 1,000 times and people look at you like a deer in the headlights where you pull it off, like how to set it up. And I was like, oh my God, like, do we have to do this again? This was like super easy. So the fact that there's no module that I need to connect this thing to is just a headache saver. It's like Tylenol.
Well, and you're saying this from just the ease of utilization,
Yeah.
right? Because you're saying, hey, my people just pull a cable. because that's what the funniest moment when they introduced that. I was like, "Where's the capital equipment?" And the guy just throws a cable at me. I was like, "That's a great sales pitch. You should
Yeah.
always do that."
Yeah, exactly.
Because honestly, all you do is you open the disposable and then you connect it to the cable, and that's it. You're ready to go. And I know you're seeing that from simplicity, and absolutely it makes sense. But I'll tell you something from a business standpoint, which is also brilliant, is you're removing this stupid notion that companies have had us against the wall for years, that we have to pay them amounts of money
Yeah.
for capital equipment leases.
Yeah.
That there's just, that, we've
Yeah,
talked
we
about
know
this,
the battle.
but I'm at war. Let's be honest. I'm at war, and I can't say anything because my lawyers won't let me, but I'm at war with one company that had me against the ropes with this stupid piece of junk material this big that operates a laser. Nobody knows what it is or what company, but I had to pay these ridiculous amounts of money or catheter utilizations to get this discounted. And now here we are having to have this fight. But then they have a better product that does the same and or more in a very, adaptable way. And the capital equipment is a piece, it's a cable.
Yeah.
So I mean, I don't know, how long did it take you to say this is something I want to at least test, right?
No, I mean it was quick. It was. I mean, I do a lot of orbital type atherectomy work, and so half of my PAD work is critical limb in our area. We're the amputation prevention center. That's really what we monitor ourselves as. And so a device that is easy to use and can be trans-tibial, transfemoral, is seemed to work really well for us.
You know what I'm gonna do? I'm gonna share, because I think the audience right now that's following along, and for those of you driving, do not look at the screen. But then come back and look at the screen, because there's some slides that we wanted to share today on this particular device that both Chris and I have used a lot and feel very comfortable with. So this is the Revolution atherectomy, and I'll let you take it away, Chris, and show some of these slides.
It's just real funny. You just said that same thing when you had Andre Schmidt on, and like don't look at the screen. And I'm driving down the road, and I'm thinking, how do I get to do both? But
Get a Tesla and have self-driving.
invest in Tesla, and now FSD, go for it. All right, so this is the Revolution device that we were just discussing, talking about. One, no capital equipment. It's a fairly simple device. Has bidirectional cutting. It has a small cylinder, football-like cylinder on the end of the device that has a diamond coating to it, and it also has the ability to aspirate, which allows us to remove that embolic debris, but also thrombotic debris. So the equipment's basically what you see here. You have a handheld control. You have an on and off switch. You can have slow, fast. It is active aspiration into a small little bag that we can actually see the debris in, and it runs over your basic wires. I'll usually use a steel wire just to keep it simple, but there's options on that. So this is the bidirectional coated burr. It's got diamond coating on it. It has a rotating core that will aspirate as you pull back through, and it goes through your basic 6 French, 7 French systems to perform atherectomy and thrombectomy.
And you're doing 6 French consistently through tibial, so it's like tibial access.
I heard your talk before, how you like to do like bareback through a lot of the tibial. One of the things about this is I started the exact same way, where I would use micropuncture, get an access, get a wire, go across, but I would never really upsize to a sheet. And until that slender technology kind of came through, with that micro tip that lets you go through the tibial. We slowly started with like 5 French, 5 French sheets, and then we was like, okay, is that safe? And yeah, I think it's safe. Um, and then we'd kind of upsize to a 6 occasionally, and we got away with it, and it seemed to work okay. And then we realized really what we were doing, and so a lot of times, we will almost always start with the 6 French sheet, sometimes upsize to a 7 at the tibial level, and we would preferentially place that sheath in single vessel runoff, because the disaster is if you have something embolized past that, um, you're in trouble. And we've all been there. It's a bad feeling you have in your gut. But the advantage of a sheath in place is you just simply open it, and that drains out anything that is potentially in that column of blood, and I just call it embolization management. So as balloons and sheaths come out, or balloons come out, or device comes out, we just open the sheath. Any debris comes out with it. You can see it on the film, and it's this way to kind of manage things.
Oh yeah, I do that the same, by the way.
Yeah.
I started only doing like retrogrades for crossing, and then I very quickly realized how advantageous a lot of these cases can go, even from a time standpoint, right? You can move the patient quicker. The time they have to be laying down is also quicker, and then you start pushing the needle. You're like, okay, I'm going to do more of these, and then and so since then, what I started to do with most everything is just the 4-5 slender, right? So it's 4 on the outside, but it's 5 on the inside. It's very flimsy, but you're not doing it at an angulated entry. You do a really nice soft entry on the skin, and so the sheath lays perfectly. And to your point exactly, Chris, is I open that valve when I'm pulling a balloon out. And so what happens is that balloon's dragging everything that's sitting there, and everything comes out, and you start seeing the squirt. You're doing a little atherectomy, you open that valve. Everything that comes down your way is never going to go to the foot because it's gone primarily through the sheath and outside of the body. So it's this automatic protection of outflow in these patients.
Yeah, and you don't see like there's any type of access complication.
Not here in Tennessee, never ever. I was, looking at maybe presenting some of this to our colleagues, our vascular surgery colleagues, and I'm waiting to get shot by them. Of course, you're sticking a what in a tibial vessel? How are you doing? How do you justify it? Well, we looked at 1,000 cases of trans-tibial access, 6 French or 7 French, and it was 50-50. The access complication rate was less than 1%, either occlusion, maybe a little PSA, or possibly an AV fistula. Um, but that was, Miguel, I would just say, when you decide to stop using just 5 French device and want to use a 6 French device from below, drop that 6 rain in, or that 6, that slender in. I don't want to talk about other device, but I've done hawk from ankle before. I always say it this way: patients teach you lessons. And so I typically use the 6 French for a long period of time. And then I did this great, beautiful atherectomy and cleaned out this SFA popliteal junction and realized there was a popliteal aneurysm. And so I jumped up to a 7 French sheath and put a Viabond across it. And it solved the problem, fixed the patient, fixed the aneurysm. Patient could walk again. And I realized, okay, this is something we can do and do fairly safely. So in my books, 5, 6, 7, at the tibial level has not changed complication rate. Now it does in proximal SFA and common femoral, because the bigger, the higher the bleed risk. And there's a lot of kinetic energy at the femoral level compared to the distal levels. So the bleed is more severe and potentially life threatening if it's common femoral.
What's crazy? How I adamant am I about ultrasound for everything you do? And so one thing I started doing when I would pull these, again, the 4-5s, which is what I do the most, is I would pull them and I would put the ultrasound to just see what, how it would respond. And I'm not going to lie to you that multiple times, and not a small fraction, I'd say 20% maybe, you would pull it and there would be no bleeding. Like absolutely no bleeding on ultrasound outside of like whatever that neurovascular bundle is that kind of tightens it up would immediately just seal the little hole. And because I wasn't putting any pressure, I would just pull it to
Yeah.
hold pressure under ultrasound guidance.
Are you
Now,
doing
sometimes you do see it and then you hold pressure, but it's like 5 minutes.
are you
And
doing primarily tibial access at all? Now that
yeah.
yeah.
Oh yeah, a lot more now.
What percentage do you think, Chris, your cases are primarily tibial access?
So I'd say it's in the order of about 80% for most PAD work. Now that the alternative is the other 20% really is SFA access. So almost never stick the common femoral in the outpatient world simply because I can't go fix it if I need to. Now, if I'm in SFA and you have if you're going integrate SFA and you're fixing a Rutherford 5 foot and you need to be in multiple tibial vessels at one time, that's where I use integrate SFA approach and use that same concept, the more of the slender type technology, because I think it works as far as ease of access and less trauma on the SFA. But and then we just use closure device at that point. But most of our trans-tibials, we walk them within a half hour. We watch them for around another half hour if they're, waking up from their anesthesia and doing fine. We have a little pressure dressing that we leave on for 24 hours, and they're instructed how to use it and when to take it off. But the complication rates are extremely low. The contrast utilization is extremely low. You can map the whole limb with about 10 cc's of dye. So there's just a lot of advantages. You're sitting at the ankle and you're not near the C arm. You're not hugging the C arm to get down that right leg from an up and over approach. And the radiation dose is, I think,
And
less.
here's another one that your guys are maybe going to find dumb, but I actually have a stool.
No, so I visited Chris in Chattanooga a long time ago, and I saw that. Yeah, you also sit at and I'm
You
like,
can sit down for the procedure.
I know. You get a nice chair, like
You
a
get
nice one.
Yeah, I have a nice ultrasound chair that I pull into the lab, and sometimes I'll just sit.
Comfy.
You have your arms rested easy, and you're just working. And I sit for probably 90% of my cases.
Oh, okay.
Yeah.
Okay, so it's not that stupid. That's funny. I felt like a little slob doing that, but
no, it's good
it's
for your back.
ergonomics.
Yeah, it's great for your back.
It's good.
Yeah.
Listen, when you get up there in age, you realize
Knees.
the bad posture kills you.
Yeah.
That radiation source is under that bed, right? So you do have to get a shield to kind of block it. I'll pull an extra shield in just to kind of, just protect myself. But yeah, I mean, honestly, it's very comfortable. Saves your ankle, saves your neck, from reaching down so much.
So, Chris, I wanna get us back on track with
Miguel, please.
presentation. But I want to go into this next video because this was for me the aha moment, and maybe you shared differently, but I'm gonna advance it, and you can walk us through.
Yeah, no. So this is great. So basically, to the right of the screen is where they're aspirating the outflow, and so the left side of the screen is where they're aspirating the debris, and so they have it, the two canisters mixed. But what you're seeing is that all the debris is being pulled into the device, and you're seeing it fill up in that aspiration canister. And there's really nothing on the other side. And so I agree. This kind of really shows you kind of how it works, but it also kind of informs you how you should use it too, because you really want to go slow, back and forth, work through that lesion, give the device some time to aspirate, and make sure that you get all the particulates out. And I think that's that's where it's at.
Yeah, and you can actually see it, man. You can actually. Let me just show this one because this is a case. I don't even know who did this case because this is one of the stock cases they had shared with us from the company Veryan, and the guys at Rex who had that Revolution catheter. But you get that bag of crap, and you open it and you cut it and you drain it and obviously this is a non-scientific thing, right? We're not even like trying to measure here, but you drain it on a towel, and the amount of particulates that comes out is crazy, which to me makes it think all of this would have just gone downstream.
Yeah. I mean, we've had people
what the
talk
hell?
about this
We've been
concept
doing
before.
this for
Yeah.
years.
Yeah, we've been doing this
And
for years.
accepting
Yeah.
because it's quote subclinical.
Yeah.
But dude, when you know a patient for 10 years and you've done angios every other year, inevitably one day you're going to have no outflow. And I think that's the aggregate from multiple endovascular interventions.
How much of that outflow is what we're doing?
Absolutely.
Yeah.
I think it's one of the main reasons it's just never been
And the thing is, like,
pointed out.
as we talked before, like whenever you do a carotid stenting, your ass is just like puckered like that because you know that one little flick of something goes on is a stroke. But like in the foot, we just like,
don't care.
Oh, it's okay, it's fine.
Well, I mean, theoretically, as long as you're effluent or the debris is less than a couple microns, your red cells are 7 microns. So if you're, um, 7/1000th of an inch, if your, debris field is less than that, it should work through the venous system and picked up by the reticular endothelial system, liver, bones, things like that, and reprocessed. But no, I agree. You get some macro embolization. You're going to start taking out some small capillaries and some problems. But again, having a device that has active aspiration and can do, this particular device can do thrombectomy as well as atherectomy in the PAD, arena.
Have you used it for tibial thrombus?
I don't think I have directly saying that, hey, this is a fresh occlusion, but I wouldn't have a problem with it. I think, uh, coming from either antegrade or retrograde approach, I think you just go slow. The device has diamond bit, on that football shaped, orb that's rotating at 40, 60,000 RPM. And so it's really going to interact with hard things. But, just that mechanical movement of that will also break up debris and pull in thrombus and pretty much anything it probably comes in contact with.
Yeah, I had an extremely satisfying experience on a patient that came with a subacute limb ischemia. She had a long stented SFA and occluded. Typical thing, right? GI bleed, something, everybody stopped their meds, occludes, comes to the clinic with a subacute limb ischemia. So I take her in, and I'm gonna do a right up and over, and then there's these like iliac stents and all this bifurcation, and I barely get up and over. And I'm thinking, because my go-to for a lot of thrombotic SFA stuff is a Rotarex, as you know, and I barely get this thing up and over, and I know Rotarex is a terrible device to
Yeah,
do
to
that,
go
right?
up
I
and over.
cannot go on this super acute bifurcation calcified. It's gonna clamp down the device, and even though this one has also the same, conceptually speaking, right?
Archimedes
There's a
screw.
Archimedes in the middle. It's much more, nicer and softer, and it goes much easier over. The components are much more flexible. So I ultimately elected to do a revolution through that, and I was puckered, to your point, because I was like, I don't know how this is gonna like really do. And I was amazed beyond belief that this whole thing was like open. Like it did really well. I was
Yeah,
very slow, to Chris's point. Like I was going back and forth. I was letting the device do its thing. I was making sure that the system was cool, my hands, the catheter, because the moment they heat up, you know that something's off.
yeah,
But we were putting infusion and man, it looked great. And so not in tibials to your point before, but I can account for SFA thrombus in a stent, and it was remarkably good
yeah.
in that particular case. I think you had a case that you wanted to go over with us.
Yeah, sure. And I have got a couple slides that we're going to move through, and the diagram that we have is from our ultrasound lab. And what you can see in that left leg is a 61-year-old female that has a critical limb in her at her left foot with a non-healing fourth and fifth toe wound, and it's been a number of weeks that it's been present. The ABI is 1.6, super high. The toe pressure, however, is 98. We have triphasic femoral popliteal flow, monophasic at the DP. So she should be healing, just by that test. But we know that doesn't really work that way. Um, so what we did was as you can see, we accessed the proximal SFA going antegrade.
Chris, let me ask you a quick question. What made you go SFA antegrade, when you normally would go pedal for this sort of case? What's your thought behind that?
So this was a rough for five, and she had fairly normal toe pressures. We thought we are going to probably be in multiple tibials and probably below ankle in that particular case. When I'm looking at multiple tibials and it might be an outflow issue, then I'm really looking at kind of an integrated approach. Because I think about 15% of the time in our advanced CLI patients were below ankle in therapy, and so it's a pretty high number, but we're aggressive to that toe, basically. And if we can get that flow across the pedal arch, then we should be safe. Now, in this image, you can kind of see mid SFA. She has like a rocky road, little mountains of intimal calcium all through that mid to distal SFA, and then the last picture shows a kind of an aberrant intertibial that comes off above knee, and then a long TP trunk. I mean, it's from above knee all the way down to the typical bifurcation region with a perineal artery outflow that we can see, and you can see the disease all through that really long aberrant TP trunk. And so, our next slide is really we have a pictorial way that we display our therapy, and which is cool. It's called med streaming, and I'll plug it real quick, but we basically put in what we did, which generates language, which generates CPT, and it's been out for about 10 plus years, but it's a pictorial way of actually it's kind of how you would say, listen, I did an angio in the SFA, I did an angioplasty, I did an atherectomy, I put a stent, and it records everything in that way. Generates language, generates CPT. I basically review it, and my operative note is complete, which is awesome.
So wait, this software then obviates the need for you to even send to a coder to polish, or
Well, I wouldn't say that. So the nice thing about this is it creates the codes. It'll do left right. It'll give the basic structure of it. Now I will always go back through and make sure that the nuance is correct, and that's it is accurate. If I'm sending it to Medicare, I will need that corrected, and then we send that to our billing company that will re-review things, and then send that back to us to finally adjudicate that to send out. Yeah, you definitely need to have a couple layers there just because you have to be accurate. And so in that next picture next to it, this is after the revolution's passed. You can see that pretty much all the little mountaintops are carved away from that mid SFA and popliteal. And then at that below knee level where that we had that really strange long TP trunk, you can actually see adequate flow now, and then that dumps into the perineal, and then that drives to the ankle, and you have a posterior communicating artery that fills the medial plantar. Lateral plantar is gone. You can see here that the pedal arch is really not intact. The dorsal pedal comes in. You don't have a strong arch, and so what my plan was for this patient was to see how she did. We've done a lot. We haven't gone past ankle at this point. If she were to start healing and the acceleration times that we test post-op are better, and she's clinically getting better, then I would be done. Now, if she isn't, then I'd be looking at going down AT across that arch and trying to reconstruct that lateral plantar. But it's a complex case, but she did well post procedure. We had her ultrasound testing looked great, and her clinical, her pain scores were better. So she's still in the process of that healing that wound at this point.
that's super interesting. You and I align on so many more things than I even knew, but I'll bring the reason why I'm saying this. Yesterday, this past 3 or 4 days, the European Society of Vascular Surgery had their annual meeting, and Matt Menard, who well, leaded the best CLI charge, did a subgroup analysis of the endo branch and came up with this conclusion that he presented it because it was all over X yesterday, that multi-tibial vessel interventions lead to better outcomes in CLTI patients. And it irked me so bad because I was like, I do the absolute opposite of that. I feel that when people, and I not and it's not a feeling, it's a hemodynamically proven thing, because that we're huge on pedal acceleration and pedal mapping hemodynamically. Every single case of a good anterior or posterior perforator vessel that feeds the tibials, I'm sorry, the plantar loop, be it complete or incomplete, is as good as trying to get a 30 centimeter CTO done. And this 30 centimeter CTO has a patency rate of like less than 2 months. Whereas getting an SFA in line to a TP trunk that was a shorter lesion is going to give this patient way better long-term results without having to put them on the table every time.
Yeah.
And here's the other kicker. Even if you say, okay, well, what's wrong? Just do more. Okay, contrast? and radiation for my team. No.
And embolization.
And more risk for complications. I mean, the
Yeah.
more you do.
Yeah.
See, that's the thing. Is there enough perfusion pressure to actually um, change the clinical, issue for the patient? Is it healing? Is it the pain gone? And so I'll take a kind of a multiple approach to this, where I do what I think is appropriate, getting as much circulation to that pedal loop if I can, or at least to the foot if I can. And then I wait and I see, if the patient's getting better clinically, we check pedal acceleration time. So we actually have a physiologic way of saying, are we better than what we were pre-op? And, is it back to normal at this point? Is the flow actually normal? Now, she is not normal. She won't be normal. She's class 2, class 3. Um, that's all I'm going to make her right now. And we're on the edge. So, medical adjunctive therapy is also important. But kind of jumping on to kind of the next the device selection side, we have really four different diameters: 133, 166, 20, and 2.3 for your larger lumen SFA popliteal regions. There's different links, especially if you have a big practice where you're coming transradial. I do not. I like to actually come right close as I can to the lesion. And there's a pedal short one I've not used before. Miguel, I'm not sure if you want to comment about there, if you use that one.
I love it. I'll tell you why. Because I'm in the camp with 4 or 5 slenders, even for antegrade cases like this. And as long as I have a good duplex and what I'm targeting, let's say it's a patient that has distal popliteal TP trunk, but proximal tibial disease, you've got a 4 French active aspiration, 60 centimeter working length. So 60 centimeter with an antegrade SFA gets you almost to the mid tibia. And so I never take out a big device if I'm working. And it's just so nice because you do antegrade all the way down and it's shorter device, like, it's easier for the OBL to handle.
I
I
could
I
see it.
I love the Shorty for French. I actually what I have on my, what I ordered from them is the 2 mm 6 French, the 133 in the 145 length, and then the 133 in the Shorty. Just those 3. That's what thus far I've felt I needed from them, and it's worked really well.
What do you have, Chris?
So I'd like to I pretty much use the top four. So the 133 all the way to 2.33, and I use the 145, and so that's pretty much all I have on the shelf. But it seems to work really well for what we're doing. Now there was a multi-center trial that the Revolution did undergo. What it did show was that they had really complex lesions, greater than 65% were below the knee lesions, 55% moderate severe calcium, 21% had CPO. So these are the tough ones. This is your critical limb patients. But in the intention to treat and also in the per protocol group, very similar kind of levels of disease that they had.
What are for you like no-brainer lesions where you would use this device? Like if I see this, my algorithm tells me I'm doing this.
Areas that are heavily calcified. So it's the people so a lot of it has to do with demographics. So the age group of that patient, if it's advanced age, they tend to calcify. Your renal insufficient patients, or people with just that intimal popcorn kind of calcium that you see in the lumens. That seems to be the area that I've gone after so far. I'm not put it into a thrombosed SFA that was just newly thrombosed. I just hadn't had that. I guess I would have been more of a Rotarex patient, but like I said, patients teach you. And Miguel, you had that patient you couldn't get up and over, and no way there's going to be a Rotarex. It's going to be a Revolution, and so you used it anyway. This IDE trial had 132 lesions in the group, and it was mostly below knee. The access was either ipsilateral, contralateral, and um, they had about one lesion per patient, and then a couple had about 20% had 2 lesions. again, moderate to severe calcium, and definitely some thrombus in their trial. As far as primary endpoints, um, everything looks very positive. The 30-day from major adverse events, 97%. The freedom from target vessel perforation, 99%. Freedom from PLR, 100%. So good technical success rates, minor secondary, problems, all within the standard vascular population. Primary pregnancy rates, at 81%, 6 months. So all seem to be pretty much within, what we would expect from a device.
I'd point out also that this was with you had an independent core lab adjudicated. So as an operator, you use it and then you say, because they always ask you, and I always find it funny because they're like, "What's the beginning lesion?" You're like 90%. What's the end up lesion? I don't know, 10%, 5%, whatever. But obviously, the core lab actually uses the angiograms, digitalizes them, and confirms this data. So I think it's a very nice mantle of safety in the sense that this is pretty vetted data.
Yeah.
It's clean.
Yeah, when they ask you TP flow 1, 2, 3, I was like, oh my god.
As far as their adjunctive devices, predominantly 95% was simply uncoated PTA. You could use drug elution if you want, cutting balloons if you want. They had some bailout stenting and drug eluting stenting that was done. But in my experience, it does a good enough job that it's simple angioplasty afterwards is really pretty much all I've had to do.
This is the last slide on the revolution, and then the other thing that we wanted to bring to the table today for our listeners was a little bit on our stent selection. Whoever knows me and has followed me for a few years, I was one of the first people to fall in love with the Supera stent. I feel interwoven technology, it just made absolute sense. The crush resistance that it brings to the table. Um, but one of the things that the biggest problems I had with it is you can't land the damn thing. And
Especially
the
the
proximal. You
the
never know.
proximal.
You
Yeah.
never know.
Yeah.
It doesn't matter how good you are.
It's like a box. It's like a box of chocolate
You
for us.
never know where that thing's gonna end.
I landed 100% perfect every time.
Every single time. Yeah.
You see, 80%. You said 80% of the time you go from the bottom. So 20%. No, you're totally right. You're totally right. But and actually, Mariano Palena, a good friend of the pod and a guy that works in Italy, what he does is he actually goes retrograde, no sheath, puts the supera from the
Really?
bottom to attack the ostial, and then just pulls the supera out and holds pressure. And I wouldn't necessarily recommend that. I've had some pretty bad complications with that retrograde access just to try to deploy a stent. But anyway, all that to say, there are other technologies that offer mimetic properties, vascular mimetic properties, but allow you to land a little bit better. And I wouldn't say it's the cheapest stent on the market, but it's not the most expensive stent of the market. And I'll share this one particular case with me. Just to show you, this was a patient that had gone to a different facility. He'd already been offered an above the knee amputation. I don't even know if he would have healed an AK. If you look at that
Yeah.
pretty crappy looking profunda, had some moderate stenosis in the common, and then that CTO of the SFA. And then what you see on the bottom, by the way, you couldn't see anything on the bottom. I went down, I took this angio. I don't even show you because there's nothing that I could see come back. On ultrasound, we saw that the posterior tibial had sluggish flow.
Okay.
And so I knew that that was open. So I went ahead and put
This is an OBL case.
this is a typical OBL case. Yeah, yeah. This is a Chattanooga OBL level case. Okay.
Yeah.
So we go posterior tibial at the ankle, and this is actually a microcatheter from the bottom showing you the what seemed to be the only island of patent vessel is that little popliteal. The PT by the leg was open, but obviously, it was a tough case. So, we went from above, we went from below. I like personally to meet in the CTO because I feel it's the safest way to protect the lumen, both the entry lumen and the re-entry lumen, if you may. Um, And so once we got these, and as you can see, obviously, here's where I splurge a little bit on my OBL needs, unfortunately. But I love Navicross catheters, and I don't still feel that I have a great option that comes in the sizes that I like, because I always use the 65 018 from the bottom. I've told you multiple times I like short devices so I can do pedal stuff.
The Navicross doesn't come in 65.
Yeah, of course it does.
It's a 90,
The
no?
018, 65, 90, 135,
Oh,
150. Those are the
I
four
only have
sizes.
90s.
Oh, that's for the 65, brother, because it
Yeah.
saves you a lot of
Okay.
headaches. Because you could use it with a 150 V18,
Yeah.
or a Command 18, or whatever you want.
Yeah.
But you use it with a shorty wire.
Yeah.
So it's like all there, and you're not dealing with people dropping
What
the
wire do you use for this in the OBL?
What's your
Yeah,
workhorse?
what's your go-to in the OBL for this?
And we have Navi on the shelf too. I mean, I always say, cheaper is not faster. Fast is important, especially some of these really complex patients in the outpatient. So I've broken more V18s, I think, in my life than
Lucas has probably broken more hearts than V18s in his life.
No comment. That's why I use a Glide Advantage. It doesn't break. That's expensive as F.
Anyway, as you can see, but let me just make a comment to that. But from a technical standpoint, V18, I love it. I have the 150s. It buckles, it knuckles up very nicely. But I've taken a love affair, and I've now started to fall deeply in love with the Asahi Mongo wire.
The one that has the automatic
Because
knuckle thing.
it actually builds into a little, it's almost like a screw. Like it takes that last centimeter and it just kind of corks it around itself, and it makes the perfect micro knuckle.
Yeah.
Now that's the 014. There's an 018 too, but the 014, man, when you're trying to re-enter on some things, it's crazy beautiful what it does. But I digress. But anyway, we did this. We were luminal. We had confirmed with IVUS. We debulked this with laser atherectomy. And then we did aggressive pre-ballooning of this. And when we did that, this was so there was flow, but these were the images. Obviously there's what seems to be clear areas of multiple dissections and recoil. And I could show you this IVUS here. This is the run after this laser plus ballooning angioplasty. Like you could see, there's a lot of junk in there. There's a lot of dissected areas. It just doesn't look great. I don't think that this is a case that I would feel comfortable leaving
Just DCBing or
like
something.
that. And you saw the wound, right? I mean, that was a bad
That's
wound.
a bad wound.
He's going to need a TMA.
Yeah.
Ideally, you want him to be a good patency
You
rate
need 90 days.
to get this healed. And I don't know that this thing would stay open with just balloon. So anyway, I ultimately said, okay, well, I need something. I'm not going to do a full metal jacket on somebody that won't ever be able to walk, right? You need to have mimetic properties, and that's where I elected it. And I needed to hit a pretty osteal SFA lesion, and so I wanted it to be a good landing. And I do a lot of that landing even with ultrasound, because I also have gotten to realize that the profunda ostium you can never really get it perfect on angio sometimes, and it's great to like double check where the stent's gonna like fall when you're and you can see it with ultrasound. But anyway, this is the bio mimic stent. That's the Veryan Biomimics 3D vascular stent. And as you can see, it's a laser cut stent, which means that it's very predictable where it's going to end. It looks exactly like a normal stent, but the beauty of it, it's cut in a way that it allows for a lot more conformation. And this is a bent knee angiogram showing the difference between when you have a very rigid, straight laser cut stent versus when you have a biomimics that accommodates. I'll show you a video there that's a little telling. See imagine this person walking 1,000 billion times a day, angling, sitting, getting down to put on his socks. This is how that stent is reacting. And on the right-hand side, you can see some of the competitors, right? All the way from Alluvia, LifeStent, to Everflex, Complete to Zilber. the kink that they generate on these tests is incredible. And so, I think it's interesting, and I ultimately this is what I did, right? I ended up putting 3 of these stents. The longest one I want to say is 150. And then I went down past my access point, confirmed that I had a very good posterior tibial outflow, ballooned that PT that needed to be ballooned, and got a good result. This is 6 months in. He had a beautiful TMA, and that stent 6 months in looks, as you can see, looks just gorgeous, right? Normal pedal acceleration times, normal velocities, no drop off, no evidence thus far of ISR. Of course, that doesn't mean that it will stay this way. It's early on. It's just 6 months. But when you look at the Mimics 3, the European registry at 3 years, the clinically driven TLR for these people is in the 78% freedom from at 3 years. So, overall, I feel strongly you see the stent fractures are much less.
How often are you seeing this guy in the clinic?
We usually on the beginning, we do 1 month, 3 months, 6 months. And now that he's in remission, we probably see him every 6 months.
Every 6 months.
Yeah,
That's what I would
at
do.
least twice a year.
Yeah.
Come in, do a surveillance. Some of these people get lost and stop their meds and stuff like that. So it's almost like you have to somehow keep touching bases with them. And just to tease out the total chronic occlusions on this particular cohort, the results were actually pretty comparable. They actually did a propensity matched analysis that showed a little split, but not bad. And this was 57% of that whole European trial. So the results were actually pretty solid. So anyway, I'll stop it there. But I think it was a good way to showcase the use. At first is I now have residents and fellows. That's a new thing. A very
That come to your
Mhm.
really, that's cool.
Yeah. I'm very grateful that Christopher Charlton Owl reached out from HCA, and he said, Miguel, I really think that there's a need for these fellows to understand what this other model of care is, sites of service. And I never thought in my mind that I would be a training facility, and there you go. So I'm back in academia.
They pulled me back in.
You can never leave. Anyway, but it was cool. But and here's what was cool about it. They came and they're like, the shit we see here is far and beyond more aggressive than some of the stuff that we see at the hospital. And you're doing it under 1 hour and with 0.5 milligrams of Versed. It's incredible. And I was like, hey, that's actually pretty cool. It's a testament to the model of care, the safety of it, and to our initial part of the conversation, having the capacity as doctors and business owners to choose the material that we know is going to lead to better results.
Yeah, because then you get innovation, then you get
Yeah,
improvement. With these constraints,
I get
agree.
somebody tomorrow that says, hey, here's a catheter. Would you want to test it? And I'm like, give me a second. Let me call. Oh, wait. Yes.
No,
Done, right?
done, yeah.
It was an excellent case, and it goes to kind of show a couple of things. One is, there's no best operation. That's what I've always kind of have railed against a little bit. There's no one best operation. What it is you are trying to get that guy through that next level, which you did. You're going to give him a number of years with that stent working. But you still haven't burned any bridges for bypass. You've given him a chance to actually heal. If there's a problem in the future, we can take care of that patient. And that's one of the things, in our center. If patients come through our center for critical limb disease, to that level that you're showing, we have a 95% limb salvage rate on average over the last 8 years. And it's because we're doing things like endo intervention, and then maybe doing it again in the future, and then maybe say, okay, listen, you're a bypass person at this point, but we've extended their life and their limb for so long at this point that um, you know I have patients that are 15 years out from critical limb care, and that's you don't normally see that. So especially if they lose their leg and then they're ultimately their demise comes sooner.
Listen, Chris.
yeah,
Yep.
I was about to say, we asked for 60 minutes of your time. You've been gracious to give us way more than that on a Saturday, where you should be doing better things than talking to these two knuckleheads.
Yeah, exactly. Go do something productive with your time.
I got a whole honey-do list to go do now, so I'm going to head and do that. But
yes, you do that.
I appreciate you guys very much. I think you're doing a great job, and best of luck. God bless to both of you.
Thank
All
you,
right,
man.
Chris,
God bless
appreciate
you.
you.
Take
Talk to
care.
you soon.
Bye-bye.